Hello, everyone. Welcome to the Journal Club. This is the third in the series of 4 we have scheduled. Today's topic is evidence-based strategies to prescribe antibiotics more effectively. My name is Shruti Murali. I'm an improvement advisor at the Wisconsin Hospital Association, and I will be coordinating today's event. For those of you not familiar with this technology, we're using a web-based video conferencing platform called Zoom. As of now, all of your mics are muted and all of your video feeds are active, meaning if you have a camera attached, it's on. Even though there are a lot of people present today, this is meant to be an interactive event, and we look forward to you participating during the case studies. When you would like to say something, please unmute your line. There's a little mic icon at the bottom left of your screen. When you're done, you can go ahead and mute yourself again by clicking that same icon. If you're calling in using a phone, you need to press *6 to mute and unmute. These directions are also written in the chat. Those participating in the live session and only in the live session have the ability to earn a continuing medical education or CME credit. I will, after the event, send you all a document containing instructions to claim your certificate. One note, the portal will be active starting right after this event and will close on September 13th at 4 p.m. Central Time. You can't try to get the certificate afterwards, and there's nothing we can do to help if you miss that deadline. This event is being recorded and a link will be made available to you. If you have any questions, please put them in the chat box. The link to the PowerPoint presentation is also in your chat right now if you didn't receive it in the calendar invite or in an email last week. So any questions, please put them in the chat box, but otherwise let me go ahead and introduce to you your facilitator for today, Dr. Bobby Redwood. Dr. Redwood is an MD, MPH. He is a graduate of Rush University School of Medicine in Chicago and the University of Wisconsin Emergency Medicine and Preventative Residencies. He works full-time as an emergency and preventative medicine physician at Divine Savior Hospital in Portage, Wisconsin, and is chair of the hospital's Antimicrobial Stewardship Committee. Dr. Redwood also teaches resident physicians and publishes research as a clinical adjunct professor for the UW Department of Family Medicine. He is the immediate past president of the Wisconsin chapter of the American College of Emergency Physicians. So without further ado, I'm going to hand it over to Dr. Redwood here.
Thanks, Shruti, and welcome back, everybody. Am I on?
There you are.
Sounds good. I just want to let everyone know how heartwarming it's been to really have the conversation ongoing, both online and offline, about antimicrobial stewardship in Wisconsin. So after each one of these webinars, we get amazing emails, we get a lot of great feedback, and I really feel like the questions are getting more sophisticated. People are looking at their own hospital antibiograms and coming up with novel ways to use fewer antibiotics or use antibiotics more wisely. And so I just want to really give kudos to everyone out there. This is our Journal Club number 3. If you recall, the first Journal Club was about UTIs and asymptomatic bacteriuria, probably the biggest offender for misuse of antibiotics. In our second Journal Club, we talked about treating fewer viruses and using and prescribing less antibiotics in general. And the flavor of this Journal Club is a little bit different. We're going to talk about, once you choose to use an antibiotic, once you've determined a bacterial pathogen, how to strategically choose that antibiotic to either use less of it or use an agent that's a narrow spectrum. And so it's evidence-based strategies to prescribe antibiotics more effectively. As always, this is an interactive conversation, and so we really want to hear from clinicians, from quality personnel. We want to hear what's happening in your hospital. So you can remain anonymous if you like, but absolutely unmute your buttons and chime in on the case studies. The more that you chime in, the richer the conversation will be. And I want to hear from you guys what's going on out there. It's very likely that you'll hear some cutting edge information in this webinar. It's very likely that the things we recommend aren't necessarily what's going on in your hospital daily practice. And I think that's a good thing. We're trying to move the conversation forward and even stay ahead of national guidelines here. Clicker on.
Go ahead.
I have no financial conflicts of interest. In fact, we're telling people to use fewer drugs, so I don't think the companies are very interested in contracting me with that right now. These are our aims and introductions. We're going to always give a background on antimicrobial stewardship. There are absolutely newbies to the conversation, and there are people who are veterans in antimicrobial stewardship. But when we do give examples, we're going to provide new statistics, so hopefully there's something interesting for those who have been on previous webinars. Then we're going to talk about some of the times in medicine where we use antimicrobials the most, where we could actually be doing that in a more judicious manner. Specifically things like community-acquired pneumonia, dental infections, pyelonephritis. We'll talk about ways to narrow our coverage. Narrow coverage basically means use a laser beam therapy instead of an atomic bomb therapy. And then how do you actually use fewer pills or shorter courses of antibiotics? The core principles of antimicrobial stewardship are the same. The pathophysiology is the more antibiotics we use, the more often we're killing off the weak bugs. So when you use an antibiotic, you're going to kill off the weakest ones first, and you'll be left with these more robust organisms. The good thing, if there's anything good about antimicrobial stewardship, is that we can reverse that trend. So as we get antibiotic resistance, if we stick with the right drug, the right dose, the right duration, and the right diagnosis, we can actually bring that pressure off, and the weak species can repopulate our community biome, and we can once again have a more effective antibiotic. Now, we don't seem to be doing really well with this in medicine. From 2000 to 2010, antimicrobial use actually increased 36% globally. And we'll show some CDC statistics, but even with the education campaigns, even with the quality improvement campaigns, we see this trend continuing. And our latest stats show us that 39% of all US antimicrobial use was inappropriate, and up to 50% in the outpatient setting. That includes the ED setting, that includes outpatient clinics. And so we gear these presentations a lot towards outpatient use of antibiotics, with the goal, of course, of reversing some of these trends. Now, in the past, we were able to get away with just inventing new drugs, right? So if our antibiotics aren't working anymore, let's discover some new antimicrobials and try to fight infections that way. In the 1980s, we had 16 new antibiotics. In the 90s, we had 10 new antibiotics. In the 2000s, we had 5 new antibiotics. Between 2008 and 2012, there was a single new antibiotic introduced. If you look at our pharmaceutical industry, only 1% of the companies actually have antibacterial discovery programs. The low-hanging fruit here has already been picked, really, and antimicrobial discovery is no longer a viable strategy for combating resistance, and so we have to change how we prescribe, and that's why we're all here today. The CDC just in April gave us some updated statistics, and this is overall antibiotic resistance in the US, and so we see over the past decade, the rates of antibacterial resistance are moving up from around 6% to around 10%, and so we're definitely seeing an increase in this. A lot of this is driven by E. coli for UTI and then macrolides for community-acquired pneumonia. And so we'll be touching on both of those topics today. And then there's this. The World Health Organization gives us a pretty stark reminder of why we're here at this webinar today. If left unchecked, the deaths from multi-drug resistant organisms is on course right now to outpace cancer deaths by 2050. And so we could be dealing with a really true pandemic here if we don't curb antibacterial resistance. Now, when we talk about overuse, that's a pretty broad term. What does overuse actually mean? It can mean a lot of different things. And you know, we've kind of been on a search for the perfect term for overuse. Overuse can sometimes sound a little judgmental. I don't want anyone to feel judged here ever. I can tell you that I overuse antimicrobials on a daily basis, all right? The goal is to get better, and perfection is the enemy of progress. For things like UTI or asymptomatic bacteriuria, overuse right now is around 80%. For UTI, 80%. And so if you're overusing at 50%, you're already well ahead of the curve here. So again, perfection is the enemy of progress. There's no judgment here. We're just trying to make wiser choices that really consider our population health, not just individual patient health, which is obviously still important. So the first journal club, we talked about treating viruses with antibiotics. That's clearly overuse. I think we can all rally around that. Another example would be when we choose an antibiotic that's unlikely to be effective against a suspected pathogen. And so we'll get into that in this webinar, but azithromycin is a great example of that. In the upper Midwest, azithromycin is unlikely to be effective against community-acquired pneumonia, and that would be an example of overuse. Using an overly broad-spectrum antibiotic, so the quinolones are a great example of this. These are very broad-spectrum agents. They're very effective for individuals, but they're now becoming resistant. We're losing our quinolones fast. Double coverage when single coverage would suffice is overuse. Cellulitis is an example of that we talked about last time. If you don't see examples of, or if you don't see evidence of MRSA or gram positives on clinical exam, then you don't require double coverage. And then using antibiotics in too high of a dose or too long of a dose. And I see this a lot with order sets, actually. So if you plug in Augmentin into your computer and the only thing that comes up is 10 days of Augmentin BID, there's a pretty good chance that you're overusing Augmentin routinely, because Augmentin, you might only want 5 days of Augmentin or 7 days of Augmentin. But when you see these order sets come up like that, that's a red flag for overuse. And then finally, our final journal club is going to talk about infection prophylaxis without sufficient evidence. And so in surgery, basically in general in surgery, antiseptic technique is sufficient without antibiotics for prophylaxis for a lot of different surgeries. And we'll be looking at some specific ortho surgeries next time to try to curb some of that practice. So let's get into the case studies. This for me is the fun part. So this is where the conversation begins. We have a 62-year-old male who presents to your clinic. He has a history of COPD, pretty good vital signs except for a fever of 102. And he's had worsening shortness of breath for 5 days. He's had a productive cough, work at breathing slightly increased. He's bringing up green sputum. You listen to his right lung base and he's got crackles. He looks okay in general. His stats are okay. You've decided he has community-acquired pneumonia. You do not need a chest x-ray for this, but you want to get him started on an outpatient antibiotic. So everybody unmute your lines, and some brave soul, please tell me, what bacteria are you suspicious for, and what drug and course of drug would you choose for this? And everyone's free to answer. Pharmacists, nurse practitioners, physicians, quality personnel. We're comfortable with silence here. We're waiting for a brave soul to speak up. How are we going to treat this community-acquired pneumonia in a 62-year-old COPDer? All right, you cowards. I'm gonna go ahead and chime
Bobby?
in. But oh, wonderful! Thank you. Go ahead.
Hi, Bobby. Deanne. Can you hear me?
I can hear you, Deanne. Shoot.
My guess was strep pneumo.
That's correct. Any antibiotic come to mind?
Oh, now you're asking the tough stuff.
Exactly. Rubber
No.
meets the road. We won't judge.
Okay. I actually no. I don't have any antibiotic that pops in mind. I can tell you things that don't give them, but nothing that pops into my mind of the best choice for that agent with that type of symptoms.
What would you say not to give them, just out of curiosity?
Something very broad spectrum. I would be trying to avoid, I'd be trying to find something that was going to be looking at gram positives and that could penetrate into the bronchi, the lungs. So something that has that penetrability, but won't be wiping out the other bacteria that we would have in our bodies.
Deanna, thank you for speaking up. So that's an excellent answer. This is community-acquired pneumonia, and all comers, strep pneumo is the most likely bacteria, so that's absolutely spot on there. And there are atypicals as well. So if you think about your walking pneumonias, things like H. influenza or M. catarrhalis are also on the list. And those are a little bit more prevalent in COPD. But absolutely, we want to be treating basically strep pneumo here. Now, the reason this is hard That is actually kind of a hard question. It's because there's not a lot of stewardship-friendly choices. You know, I think traditionally the things people are using out there, correct me if I'm wrong, and I kind of polled my ED colleagues on this, are things like azithromycin, levaquin, or moxifloxacin. So basically a respiratory fluoroquinolone or a macrolide are what a lot of people are using. And the problem is those are both either ineffective drugs or drugs with high side effect profiles or drivers of C. diff. So they're not very stewardship-friendly choices. If you look at UpToDate, UpToDate is still recommending azithromycin, and they're still recommending it based on 2007 guidelines from IDSA. And so we're going to talk about that, and we're going to make a specific choice that's different from UpToDate. We all know UpToDate is not always up-to-date, right? We're going to recommend doxycycline, 100 milligrams BID for 5 days, and we'll tell you why. So we're not allowed to use trade names here, but a certain drug has been marketed since the late 80s as the azithromycin pack, and I call this a tragic love story. So the azithromycin pack was one of the most successful marketing campaigns in medicine, and when the data was first collected in 1993, the macrolide prescriptions for adults with infections for strep pneumo was already up to 20%. And from 1993 to 2006, it went from 20 to 30%. So 1/3 of all people with pneumonias were getting treated, and probably some people with bronchitis, right? Were being treated with this very broad spectrum agent, this very potent drug, 1/3 of the time. Now, the resistance rates just totally track the prescription use. That makes a lot of sense. That actually supports our theory here that as we overuse these drugs, our resistance rates go up. So in 1994, the resistance to strep pneumo for azithromycin was 10%. In 1995, it was 35%, just 1 year later. Fast forward to 2009, and half of all strep pneumo was resistant to macrolides, to azithromycin. Okay, and these numbers are particularly true in the upper Midwest. So we're north of 50% resistance to azithromycin in the Midwest. So in my mind, this is a useless drug. We have trashed azithromycin for community-acquired pneumonia. Now, if you look at that UpToDate guidelines, nobody reads the fine print, right? But let's read the fine print for a second. Who should not be getting azithromycin? This is even per the 2007 guidelines. Anyone over the age of 65, that's already a large proportion of your patients. Anyone who's recently been treated for a community-acquired pneumonia with a broad-spectrum agent, so cephalosporin, a macrolide, a quinolone, the immunosuppressed, the patients with lots of comorbidities, exposure to daycare center, and then Midwest region. So even if you are using those 2007 guidelines, we are excluded because azithromycin resistance rates are so high in our region. And for that reason, we're really strongly recommending doxycycline. These are the ways that I'm seeing azithromycin being misused in community practice. And I feel very comfortable saying misused because it's effective 50% of the time. We got to think about that. So the azithromycin pack alone for community-acquired pneumonia, we're talking about that right now. If you found it's really effective in your practice, I question whether those are actual pneumonia diagnoses or whether we're treating bronchitis. We talked about that in our second webinar, how there's actually a lot of viral bronchitis out there being treated as though it were community-acquired pneumonia. So that's one thing to think about. Now, the GOLD criteria, the GOLD Consortium on COPD, still recommends azithromycin for moderate COPD exacerbations. So your COPD patient with no proven pneumonia, the Specialist Society is recommending antibiotic treatment. I don't think that's very population health friendly. I don't practice that way. If I'm really suspicious, or if I'm really unsure, maybe that's a virus, maybe it's not, I'll actually send a procalcitonin for those people, and that's FDA approved as of 2017. But I would not recommend following the GOLD criteria. I would not prescribe azithromycin for community-acquired pneumonia. If you are for COPD exacerbation that doesn't have evidence of community-acquired pneumonia, if you are going to follow that criteria, then I would recommend using doxycycline. And then we already talked about bronchitis. I think we're overusing azithromycin for bronchitis. Now, these are our best practices on the right-hand column. And so if you have any power over putting in suggestive antimicrobials in your health system, start with doxycycline, 100 milligrams BID. And for patients who have a severe infection, you can start with a 200 milligram loading dose. So for that very first dose, you can do a 200 milligram dose. And I do that for 5 days. I think when the IDSA recommendations get updated, and they're promising us an update this summer actually, you're going to see doxycycline as a first-line agent. The fluoroquinolones are still a good choice, but they should be reserved because of side effect profiles and resistance rates and driving C. diff infections. And so I reserve those for A, patients who are being hospitalized, or B, patients who you're sending home that have more severe infections. So if someone's looking pretty good, like our patient was in that example, I wouldn't recommend a fluoroquinolone. And then there is still a place for the azithromycin pack, but it's third line, and that's for a patient who, for some reason can't take doxy or can't take a fluoroquinolone. For example, if patient's already on a steroid and they're on warfarin, and a doxycycline allergy, you probably wouldn't want to use doxy or a fluoroquinolone. Then you can use amoxicillin plus an azithromycin pack. But again, that's not going to get you very far in the Midwest, where we have our resistant rates north of 50%. That was a ton of information all at once, so feel free to review the slides, or if you have a burning question at the end, we can revisit that topic. Let's go on to case 2 here. So we have a 22-year-old female, and she's got a history of poor dentition, dental caries, but she's otherwise healthy. And for 3 days now, she's been having facial swelling. It got a lot worse last night, which is what made her come into your emergency department. She has no fever, no trismus, but the diagnosis here is a dental infection, a periapical abscess that has moved into the maxillary space. And my question for you is, what bacteria are we thinking about here, and what drug would you recommend? And again, please feel free to chime in. It's going to be a much better conversation if you chime in.
Yes, someone write in chat.
Oh, wonderful. All right, so we had a chat response here. Concern for anaerobes and clindamycin as a recommendation. That's awesome. Thank you for chiming in. And I think with that recommendation, you would be in line with a lot of the medical literature. And then we're going to go a little bit against the medical literature and actually go with the dental literature on this one. And Shruti, Mike, there we go, perfect. So this is absolutely, like we said, a maxillary space infection, and this is mixed aerobic and anaerobic bacteria. So anaerobes, like you identified, so perfect. You know what you're treating. And treatment is recommended here. So a lot of times in dental sources, we don't recommend treatment. But this periapical abscess has now spread into the adjacent tissue. It's in the soft tissue, and it should be accessible by an oral antibiotic. And our recommendation, and this is also the recommendation of the statewide antimicrobial stewardship committee, is penicillin 500 milligrams 4 times daily for 7 days. And if you look at the different species there, you'll see that most of those species are highly susceptible to penicillin in vitro. And then there's this one species, Prevotella, that in vitro doesn't seem to be as susceptible to penicillin. And then we'll kind of get deeper into that question. So when I think of antibiotics for dental infections, I like to think of the few circumstances where we do treat and everything else we don't treat, okay? So these are the times when you do want to use antibiotics. If you have a dental infection that's spread to adjacent tissue, so if you have fever, if you have trismus, if you have lymphadenopathy, facial swelling like our patient here, those are all times to treat. Obviously, if you have systemic issues, so if the patient has tachycardia, low blood pressure, concern for sepsis, obviously you want to treat. But if we're talking about local dental infections, there are only 3 circumstances. And there's really only 3. So I've reviewed all of the dental literature. There's plenty of systematic reviews on this. And those are acute necrotizing ulcerative gingivitis. I have a picture of it there. I have yet to see this clinical entity in clinical practice. It happens in alcoholics and diabetics with historically poor dentition. It's a pretty rare thing. The periodontal abscess that did not drain well. So that's when you're looking at the gum line, and right on the keratinized gingiva, that pink gum line, you see a juicy abscess there. You try to drain it, and instead of getting a bunch of pus out, you're just kind of getting bloody discharge, and you say, I'm not very confident that I drained that abscess. That's a time when you can use antibiotics. And then this entity, pericoronitis. Now, a lot of dental pathology is just getting used to this terminology, but if you think about when you look in the molar way in the back, and you see the skin kind of wadded up and growing over the molar there, that's pericoronitis, and that's viable tissue that can actually get a bacterial infection, and we do recommend treating that with antibiotics. So, this is a slide to look at if you're thinking, should I treat or should I not? Most of the time, I approach these patients assuming we're not going to treat, and the patient has to prove to me that they merit treatment. That's how I approach these patients. So here are no antibiotic patients. So first, mechanical and inflammatory conditions. So patients with dental caries or cavities, we are not treating. If you see that cracked tooth or the impacted tooth, an impacted tooth is like a tooth that's growing in sideways or totally covered with tissue. That's not treated with antibiotics. If you see exostosis, Exostosis kind of looks like an abscess when you first see it. It's this fleshy wad of tissue. Sometimes it can get as big as a pea, but it's not red, it's not hot, it's not tender, there's no blood draining from it. And when you poke it, it's just kind of waddy, fleshy tissue that doesn't need antibiotics. And then any of the hypersensitivity syndromes, the food impactions or the tooth grinding, these are things that cause intermittent pain, but it just gets better on its own when the inflammation goes down. No antibiotics recommended. So those are mechanical and inflammatory conditions. Now here are the ones I think people actually get confused on. So when you get into the pulp and the periodontal region, so the inside of the tooth and the outer aspect of the tooth, most things don't require antibiotics. So reversible and irreversible pulpitis is a dental carie that's basically spread to the dental pulp. So if you look at the picture there, that black junk is now in the pulp. It would be wonderful if that responded to antibiotics, but it doesn't. Antibiotics just don't get into that tissue. So that's liquefactive necrosis. It is not vascularized tissue. Antibiotics don't get there. Now, you probably have patients who say they get better on antibiotics, and it's very likely they would have just got better on their own. Reversible pulpitis is just waxes and wanes in nature. So you get some swelling, you get a ton of pain, you get some redness, the swelling goes away, the pain goes away. It would have gone away whether the patient had antibiotics or not. If you have an abscess at the base of a tooth, we do not treat those abscesses with antibiotics. So the periapical abscess or the periodontal abscess, those antibiotics do not penetrate there. What likely happens is that actually forms a drainage tract on the outside of the tooth, and so the patient gets some low-level purulent drainage around the tooth, and it gets better on its own. You can actually wiggle these teeth a lot of the time. Sometimes wiggling it, you'll see a little bit of pus come out. Or if you have a water pick or an actual dental pick in your clinic or ED, you can do a little bit of manipulation around the gingiva. Sometimes you'll see pus come out. But that abscess is simply not reachable. The treatment is tooth extraction, not antibiotics. And it's the same thing. If you treat it with antibiotics, it's likely the patient will get better, not because of the antibiotic, but just because of time or it formed a drainage tract. And then the exception there is like our patient in the first example. So usually these abscesses are supposed to drain out. They're supposed to drain into the mouth. But if they actually erode into the bone and get to the facial tissue or into the lymph nodes, then you'll start seeing adjacent tissue signs. That's when you do treat. So that's when you're going to have vascularized tissue that's actually penetrable by antibiotics. That was a lot of information all at once. I think in medicine, we don't do dentistry very well. I reviewed the medical literature on antibiotics for dental infections, and there's a vast disconnect between the dental literature. And the medical literature, from what I've seen, is very nonspecific. It uses a lot of wastebasket diagnoses like dental abscess and dental infection. And it's based on a lot of in vitro studies, not on actual in vivo studies. These are my pearls of wisdom from the dental literature, okay? So these are direct quotes from a systematic review of antibiotic prescribing by dentists. The dental pulp tissue after succumbing to liquefaction necrosis is no longer vascularized, and orally distributed drugs are unable to reach the site of infection. So for pulpitis, for periapical abscesses, that antibiotic is not going to reach the source of infection. The second quote, there's no difference in clinical outcomes between penicillin VK, amoxicillin, or augmentin, okay? So straight up, these are actual trials. In the medical literature, I don't see a lot of trials. The dental literature is actually trying these drugs in 3 different patient populations. The medical literature is looking more at resistance rates in vitro, so lab resistance rates. And then finally, penicillin is still the gold standard in treating dental infections. So for our brave person who wrote in, I thank you. And I think clindamycin is really actually a reasonable choice. It's totally effective. But as we know, clindamycin drives C. difficile rates. Penicillin is the gold standard. And so I use clindamycin in penallergic patients. Now, if you look at the medical literature that recommends things like augmentin, so I think a ton of providers out there are using augmentin for these infections. The justification that's given is that 70% resistance. So hey, for Preventella species, augmentin is only going to be effective 70% of the time, or penicillin is only going to be effective 70% of the time. Let's use augmentin. It doesn't seem to bear out with actual patients, and there's 3 theories why. One is what we talked about. This infection would have got better on its own, and it didn't really need an antibiotic in the first place. Periapical abscess is a great example. The second reason is that possibility is, it's a little bit of a wastebasket reason, but maybe it's just in vitro instead of in vivo. Maybe it has something to do with our immune system that really boosts the efficacy of penicillin and makes it effective against Prevotella. And then the third is probably the most likely, that these polymicrobial infections are actually pathogenic complexes. So these are five bacterial species working in concert with each other. And if you kill one or two of the pillars, the entire complex collapses. And that makes a lot of sense to me, that you actually have this symbiotic polymicrobial infection, and we don't need to be killing every single species. We just need to be killing a few pillars of that complex in order to show improvement. Regardless, penicillin is the gold standard for dental infections. This is my practice right here. First, I assume that antibiotics aren't needed. So I assume one of those things like reversible pulpitis or periapical abscess. And if I have low concern, I instrument the tooth a little bit. I see if there's anything drainable, but I do not prescribe antibiotics. If I have moderate concern, I'm talking about a 3 to 5 day course of penicillin. And then if I have severe concern, like our patient with facial cellulitis, I would do a 5 to 7 day course of penicillin 4 times daily. The bigger guns like clindamycin, I'm reserving for pen allergic patients. And then things like amoxicillin or flagyl, I'm really only using for treatment failures. And so I use those drugs very rarely for dental infections. And I'm never prescribing a course greater than 7 days. Really never. I mean, maybe if I'm admitting a patient for sepsis, maybe something like that. But I'm leaning on the side of short courses, and I'm really relying pretty heavily on penicillin. You know, if you think about the next generation of antimicrobial resistance, we're going to be needing Augmentin a lot more. We might even be using Augmentin for things like community-acquired pneumonia. And so it's important to save these drugs now and not use them willy-nilly for dental infections. All right, we're right on track here, guys. So this is our final case, and then we'll talk about some special circumstances for using fewer antibiotics. So get ready to chime in now. Case 3. She's 35 years old. She's not pregnant, and she presents with 4 days of dysuria that's progressed to fever, flank pain, and nausea. No new sex partners, no vaginal discharge, and our concern here is for pyelonephritis. So this is an upper urinary tract infection. It's no longer just cystitis. We want to treat this patient as an outpatient, and we're wondering what is the most likely bacteria and what drug should we be considering. All right, so we have an answer. Patty in the audience said Bactrim while awaiting culture. And then anybody want to weigh in on what drug we're thinking about here? I'm sorry, not what drug, what bacteria we're thinking about here? Perfect, E. coli. Thanks, everyone. So I couldn't agree more. The urinary tract infections are 95% gram-negative, clicker. And most of the time, in fact, 80% of the time, that is E. coli that we're talking about. And the other 15% of the time, it's things like Klebsiella or Proteus, which are in the E. coli family. That's at Enterobacteriaceae. So we know our drug. We know we want to treat gram-negatives. Bactrim's a pretty good choice, actually, and I think Bactrim's an appropriate choice. The only problem is they stop recommending Bactrim if your resistance rates are above 20%. And in a lot of centers, our resistance rates are above 20%. So the take-home point here, which is on point, is you have to consult your local hospital biogram and know what your local resistance patterns are. So if your Bactrim resistance is under 20%, then that's a good choice. Unfortunately, for a lot of centers, that will not be the case. The IDSA recommendations is a cephalosporin, and some centers can actually get away with a first-generation cephalosporin like Keflex. So at my home hospital, our resistance rates are actually pretty low to cephalosporins, and so we can still use the first-generation choice. But for most places, we're talking about a second or third-generation cephalosporin. And so a great choice that would work in most hospitals would be a gram of ceftriaxone IV, or if you're in clinic, you could do 125 milligrams IM, followed by cefpodoxime 20 milligrams or 200 milligrams BID for 10 days. Here's how I think about pyelonephritis. The workhorse of pyelonephritis for generations, right, for probably 2 generations now, for decades at least, has been ciprofloxacin, has been the fluoroquinolones. And it's a great drug, but it's a very broad spectrum, and resistance rates to ciprofloxacin especially are just skyrocketing. And we're losing that drug. Now, for those of us who worry about superbugs, right? Lay people can have the luxury of being able to worry about things like crime and terrorism. In medicine, we worry about the next pandemic. We worry about superbugs. And ESBL E. coli is the big one. ESBL E. coli is a multi-drug resistant organism that is very likely going to become the next generation of superbug in the US. And right now it's still susceptible to carbapenems, but there are case reports of ones that are susceptible to no drugs. And the way to fight ESBL is to get quinolones back. If we save our quinolones now, then we'll have those available for ESBL organisms in the next decade. And so we've got to stop using Cipro. We've got to stop using Levaquin for pyelonephritis. And we don't have a ton of options. Again, it's tricky. So cephalosporins is the option that I would recommend. Bactrim is an option if that's still viable in your hospital. So good answers. The other thing about quinolones is they have a lot of side effects. And so I think this is just starting to be recognized. This doctor, Dr. Cohen, wrote an entire, it's like a novel, it's a nonfiction book on the dangers of fluoroquinolones. And so if you needed more reasons not to use Cipro, they're a major driver of C. diff. We talked about the resistance rates in the Midwest were around 40% resistance to ciprofloxacin. And then the side effect profile is just epic. So the neuropathies, the QT prolongation, if your patient is on warfarin, you know it's going to send their PT-INRs all out of whack. And then tendinopathy really is a big one, especially in the elderly or patients on steroids. These tendinopathies are common. And so your COPD patients should really never be getting Levaquin. If you can avoid them at all for pyelonephritis, you don't want to be using the quinolones. And so, again, we recommend the cephalosporins for pyelonephritis. Look at your biogram for Bactrim. This is our last point here. So, and we're going to have some good time for questions. So I really welcome your guys' questions. During our last presentation, at the very end, we talked about shorter courses of antibiotics. And the literature we brought up, a lot of it was non-US literature, or it was antibiotics for things like meningitis, which are kind of uncommon entities. So I wanted to talk about some of these high-risk antibiotics now and give you some literature where we can actually use fewer antibiotics. And these are the two studies that really popped in my mind that I think justify using shorter courses of antibiotics. So the first is Levaquin, right? Our goal for community-acquired pneumonia should be not use Levaquin if possible, but we obviously have those severe patients, we have those hospitalized patients where we might be using Levaquin. And this trial had 530 patients, and they actually did high-dose, short-course Levaquin for community-acquired pneumonia. So they did 5 days of levofloxacin, 750 milligrams, once daily, instead of 10 days of 500 milligrams. And they had equal efficacy, same number of treatment failures, same number of deaths, equal efficacy, and they were able to save 1,250 milligrams of levofloxacin. So again, we're not finding any huge randomized controlled trials on these topics. They're pretty small numbers, but that's the best available literature out there. And the literature to use long courses, it's not exactly evidence-based either. When they came out with these antibiotics, they just started with long courses of antibiotics. And so I think that's a very appropriate course of treatment. And if you wanted to, in your own practice, start using shorter courses for these high-risk antibiotics, you're very justified in doing so. Moving on to pyelonephritis, what you'll see in a lot of order sets is 14 days of ciprofloxacin for 500 milligrams BID. And this trial of 248 patients used ciprofloxacin for 7 days, twice daily at 500 milligrams, saving about 3,500 milligrams of antibiotic. And that was also non-inferior, the same number of treatment failures, the same number of deaths. So that's another viable option. And then I know we're talking about these high-risk medications and we're right at the end here. So I just really want to emphasize for community-acquired pneumonia, we're recommending doxycycline. For pyelonephritis, we're recommending a cephalosporin, probably something like cefpodoxime, 200 milligrams BID. And what we're trying not to do, we're trying not to use azithromycin in community-acquired pneumonia, trying not to use Levaquin in soft-call community-acquired pneumonias or outpatient treatment unless it's a severe case. And we're trying not to use fluoroquinolones in cystitis. So when someone has a UTI, we're really recommending nitrofurantoin and not ciprofloxacin at all. So let's go ahead and wrap it up here, and then I hope some people have questions. We kind of hyper-focused on a few pathologies, but if you want to branch out into other diseases or you have specific questions about what your hospital does, I'd be really happy to answer those questions. And so, like we talked about, macrolides are basically out. Resistance in the Midwest is north of 50%. They're no longer a good choice for a community-acquired pneumonia. We've been treating a lot of bronchitis anyways. First, make sure you have a solid diagnosis of pneumonia and start with doxycycline 100 milligrams BID for 5 days, plus or minus that 200 milligram loading dose. I personally use the loading dose. It takes a little more work because a lot of those prescriptions aren't written that way, so you might have to adjust your prescription a little bit. For dental infections, few dental complaints actually require antibiotics. So start with the presumption that antibiotics are not required and prove to yourself that you need an antibiotic. That is adjacent spread, so things like trismus, fever, lymphadenopathy, or things like sepsis, or facial swelling like we saw in our patient. For local infections, it's almost never recommended. ANUG is one, that necrotizing gingivitis. The pericoronitis, the wad of tissue that's grown over a tooth and looks infected, is another one. And then for an abscess that didn't drain well is the third. In terms of pyelonephritis, we are losing Cipro fast. Our resistance rates are north of 40%. And so consider a beta-lactam first. Consult your biogram. If you're lucky, you can use a first generation. More likely, you'll be using a second or third generation beta-lactam. And then reserve Cipro for treatment failures. Never use ciprofloxacin for cystitis. There's really never a good recommendation for using it for cystitis. Better choices would be things like nitrofurantoin, Bactrim, or cephalosporin for cystitis. And then finally, if you are using a broad spectrum agent, sometimes we have to, sometimes you need to use your Levaquin or your ciprofloxacin. See if your patient is appropriate for a shorter course. The literature on that isn't great, but I think is very appropriate given the epidemic of antimicrobial resistance that we're facing and the high side effect profiles of these meds. That was a ton of info, obviously. Sometimes it feels like we're drinking through a fire hose here. If you want this info watered down and synthesized into kind of easy to approach material, the Department of Health Services Antimicrobial Stewardship Committee has released guidelines for emergency physicians that we actually attach to this presentation. And so you can post these in your clinic. These are absolutely applicable to family medicine or internal medicine as well. One is the top 10 ways to avoid prescribing unnecessary antibiotics, and the other is the top 10 ways for physicians to improve antibiotic choices, which highlights a lot of the things we talked about today. And so definitely download those and post them near your computer in your clinical areas. And with that, I'll open the floor to questions. And you can type in your questions or chime in. Obviously, we love to hear your voice, so feel free to chime in. We'll start with an online question here. What are your thoughts on the ED role of a patient who reports with a penicillin allergy when an antibiotic is appropriate? Let's see, penicillin allergy for what type of infection, I guess would be my question. So while we're waiting for that person to weigh in on what type of infection they're talking about, one thing I see all the time are fake penicillin allergies. So there is absolutely a known amoxicillin rash in childhood, and a lot of people have documented penicillin allergy, and it was a rash. And so lots of times I'll actually ask people, do you know what your penicillin allergy is? If it's throat closing or anaphylaxis, okay, then we shouldn't be giving a pen agent there. But lots of times if it's just a rash, I'll actually do a trial of a penicillin agent in the ED. Or in clinic. So you have epinephrine in clinic, you have steroids and Benadryl in clinic. If the patient's willing to wait around and you're suspicious of whether that's a true allergy, so many of those allergies are overstated that I'll actually give them a course of for example, penicillin for a dental infection in the ED and say, do you mind waiting around a little while? We can do a dental block, we can work on pain control, give you your penicillin in the ED and see if you have a reaction. I have yet to have a anaphylaxis in that practice. The other thing is there's a theoretical 10% cephalosporin crossover reaction. So if I have a true penicillin allergy and I am given something like ceftriaxone, in theory, 10% of the time there's a crossover reaction and you may have an allergic reaction to cephalosporin. That is pretty soft literature. First of all, if that reaction occurs, it's usually a much more mild reaction. and 90% of the time you won't have a reaction. And so I actually feel very comfortable giving the patient cephalosporins, even if they have a penicillin allergy, and just saying, hey, if you show any allergy symptoms with this drug, come back to us immediately. And again, I've yet to have a patient bounce back with anaphylaxis or throat closing from that practice. Okay, and let's see, we have some clarification. Any type of infection due to the number of patients who believe they have an allergy. Okay, so I think we answered your question there. But to keep it focused on this conversation here, for community-acquired pneumonia, doxy is our first-line choice, so you won't run afoul of your penallergic patients. For dental infections, make sure they have a true allergy. If it's a soft call, you can try observation while you give the penicillin, or you can go to clindamycin. And then for UTI, pediatric patients would be the population here. For pediatric patients, amoxicillin is recommended for UTI. And I would really ask the parents specifically, was that a virus that we should think was treated with amoxicillin and where you got a mild rash with no itching? If the child didn't have hives, didn't have throat closing, didn't have an anaphylaxis, I would actually use amoxicillin, but just observe the child for a little bit. Let's see, we have another question. What is the difference of effectiveness between ceftonir versus cephalexin in treating UTI? I've used ceftonir often, but it's not in my biogram. Oh, that's such a good question. So the problem with our biograms a lot of the time is they won't have oral medications in the biogram. And that's just the way the lab works. A lot of times they're actually using intravenous medications to test the biogram. And so you have to extrapolate. You have to say, okay, they use ceftriaxone, which is a third generation cephalosporin, so I'm going to extrapolate cefpodoxime, which is an oral equivalent of that. So cephalexin, you have to use ANCEPH if you want to look at cephalexin. So if your biogram has ANCEPH on it, that will show you what your resistance rates for cephalexin are. But you won't see cephalexin in your biogram a lot of the time because it's an oral first generation agent. But the basic answer to your question is the resistance rates for cephalexin are getting sometimes as high as 15 or 20%. And so for a lot of health centers, that is no longer a viable drug. In my health center, it's actually only 2%. So for whatever reason, in my rural community ED, we have a very low rate of cephalexin resistance. And so I use that as my workhorse for outpatient pyelonephritis. And I don't think I can think of a single treatment failure that I've had since I've incorporated that in my practice. Now, another thing that kind of touches on your question is actually these ESBL organisms, extended beta-lactamase resistant E. coli. And so these are superbugs that you need carbapenems to fight. And you've probably had a few in your ICU already if you look at urosepsis cultures from your ICU. Now, to actually get resistance rates for ESBL organisms, you have to do DNA studies. And DNA studies are expensive. Your average hospital probably isn't going to be doing those. And so when you look at your biogram, look at your resistance rates of E. coli to ceftriaxone, and that is a proxy for what your prevalence of ESBL is. So for example, in my hospital, we have about 2 to 3% resistance to ceftriaxone for E. coli. So we probably have 2 to 3% ESBL organisms. And then you can see how many urosepsis patients are actually having treatment failures and need carbapenems like meropenem IV. And that'll give you an idea of if these superbugs are in your community. Nationwide, the numbers are around 6%. And in California especially, they're seeing pretty high numbers. And so you just want to check with your biogram and see if you're having any of these superbugs. If you have superbugs in your biogram, that's all the more reason to get aggressive about these antimicrobial stewardship protocols, especially if you have local long-term care centers or things like that. Because if these bugs get out into the community, you're going to see a lot more ICU admissions, a lot more deaths from multi-drug resistant organisms. Let's see. Other questions out there? Those were great questions. We breezed over the dental pathology pretty quick. My recommendation would be, when I started looking at the dental literature, I'll be honest with you, I didn't know what a lot of those diagnoses were. I think in human medicine, we lump a lot of dental diagnoses together without getting to the level of sophistication that dentists do. And so look over that list of dental pathologies, and if there's any words that you don't recognize, just do a Google search, usually a Google image search. And it's one of these things where like a 5-second Google search will really enlighten your understanding of dental pathology. But because dentistry is largely handled by dentists. I think we in medicine have gotten a little bit lazy and maybe don't diagnose with the same level of sophistication. So if next time you have a dental patient come in, if you just want to do a little homework or learn a little more about dental pathology, that's a great exercise that'll really increase your understanding of antibiotic use in dentistry. Great. So that was an awesome conversation. We're always available offline as well if you have further questions or if you have kind of specific questions about your hospital situation. I know I always get a lot of questions after the webinar, so thank you everyone for those great questions. Our next topic is going to be November 15th, correct?
August 15th. Oh, sorry.
I believe November.
Yep.
Is it?
October 15th.
So, October 15th, we are sure. Our next webinar is going to be October 15th, and we'll be talking about the recommendations for antibiotic use for UTI testing and antibiotic prophylaxis for positive bacteriuria before total joint replacements and ortho procedures. And so there's a lot of great literature out on that. It's going to be kind of a deep dive on a specific literature-based topic, and so we welcome everyone to join us. Thanks again for attending.
All right, thank you, Bobby, and thanks everyone for attending our third journal club. I will be emailing all the registrants a document with instructions on how to get your CME credit. And please note again that the portal is going to be active right after this event closes and will be open until September 18th, 4 p.m. If you have any questions, you can either email me or Bobby and we will get back to you. But be sure to join us for the next journal club and we will see you then. Thanks. Have a good rest of the week.